speaker, Professor Max Aebi from Switzerland. He will tell us how to make it manage proximal junctional kyphosis, which is one of the most difficult complications of long fixations.
So I try to get my talk here.
Yeah, good.
So I can do so. Okay. So thank you very much for giving me the opportunity to talk about this topic. It's certainly a pleasure. It's, about all this technology that we have, and I'm impressed how until now functions. I hope it will function also with my talk. So the proximal junctional kyphosis is a fundamental problem in this deformity surgery, and more we do that, more we realize that this is a big challenge. Masarle, one of my pupils, and myself, we published a review article in 2013 in the European Spine Journal, and much what I'm telling you here, if people are interested, they can read there, and there is also literature. What we basically realized, and we realize more and more today, that with the technology which we have available, with stronger and however also more rigid instrumentation, with powerful osteotomies that we have seen now this afternoon, and along with the progressive degenerative processes in elderly people and the bad bone quality, we are more and more confronted with adjacent segment disease. And depending from where you are coming, but depending from the age group of patients you operate, almost every third patient, even every second patient you operate with a complex deformity, they may have an adjacent segment problem or a proximal junctional kyphosis. Now, you'll have some definitions, and as I show here, we are just talking about proximal junctional kyphosis, but obviously there are distal junctional kyphosis. There are intercalary junctional kyphosis, that means between two instrumentation areas of the spine, and there are also some junctional problems with new formation of scoliosis above rigid fixations. So I'm just focusing on the proximal one. Here, this is a radiograph, a lateral view of a patient with a proximal junctional kyphosis, PJK, as we say, without a proximal junctional failure. I will come back to that in the mid-thoracic spine. So this is just a description what we have here. And this kind of kyphosis is in fact quite well correlating with pain. So almost all the patients who have really a kyphosis, a proximal junctional kyphosis, they complain about back pain in the upper spine, in the thoracic spine. So it's quite a high predictable element for PJK. Now there is evidence that the absolute PJK angle measure of which is expressing the mechanical failure is directly correlated to pain and inversely correlated to the mechanism. This instead is a proximal junctional kyphosis with a proximal junctional failure, which is different. This is of the 8 thoracic vertebra. It's a fracture in a patient we have received from outside. And as you can see, this is a real distinct entity of the proximal junctional kyphosis. Is the failure. That means this is a failure which is given through the structural failure of the vertebral body and or the posterior ligament complex. So both of this, and I will come back to that, are very important to understand what exactly is the problem in these specific cases. So the clinical findings usually are pain, neurological deficit, ambulatory difficulty, social isolation, and or inability to maintain horizontal gaze because they're bending forward, and significantly worse osvestic disability index. So this is something which is quite regular, this kind of pathology, and this is what the patients complain about. The PJK develops usually secondary to this kind of pathologies. That means progressive deformity from aging, disruption of the posterior ligament complex, fractures like in osteoporosis, instrumentation failures. Very often these elements are combined with each other. Degenerative disc disease and or facet violation. There are some pathophysiological facts we have to consider. So that's the age for sure. Older the patient, higher the probabilities that they develop such a pathology. There is an increased body mass index. Many people who are overweight, they are in fact candidates for this kind of pathology, and the osteoporosis. And pre-existing and post-operative sagittal imbalance, most relevant is this for the pathogenesis, and weakened posterior elements, which goes along with fatty degeneration of the posterior muscles, which is a very important issue. These are the key elements. And then you can also have a knee and hip pathology, which has an impact of these junctional pathologies. What the cause, what it is, whether it's the cause or whether it's the consequence of the sagittal malalignment is not so clear. Then there is conditions of non-instrumented spine above and below. That means you have stiff, out-of-fused elements, which are the natural history of this specific patient. And of course, the rigid instrumentation plays a key role. The pelvic incident is the key element, as we have heard this afternoon many times, that governs lumbar lordosis of the patient and hence the sagittal balance. So the incidence is quite variable depending on the literature, what you are looking at. But when we talk today about patients who are older than 65, you can basically assume that there is about 20 to 40% of the patients with a adult deformity they develop after the surgery, PJK. The most, that what you can see here, and what you can see also is in about 2/3 of the PJK, they arrive within 3 months after the surgery. So they are pretty fast after the surgery occurring. And certainly 80% of the patients with a PJK, they have this problem within 18 months after the surgery, most of them very early on. Now, let me go through some case examples to basically support what I just listed purely theoretically, and to better understand this pathophysiology and the mechanism. So, first case I show here is a flat back syndrome after multiple low back surgeries in a 45 years old obese patient. Body mass index massively high. And as you can see, there is a proximal junctional kyphosis, which is defined as bigger than 10 degrees. In some literature, it's bigger than 15 degrees and certainly more. Above a previous instrumented spine. Here in this specific case, it's L2 to S1. In this case, there has been done a improvement of the sagittal alignment by a PSO at L2, and there is an instrumentation from T11 to S1, which looks quite nice primarily. However, 2 weeks post-operative, the patient feels a crack in her back. The X-ray shows a proximal junctional kyphosis with fractures through the pedicle of T11, and which basically necessitated another surgery, an extension into the thoracic spine and the double rod at the thoracolumbar junction to reinforce the fixation. Another example, this is an aging process which is happening here. And you can see this is a patient with a 63 years old patient with a type 1 scoliosis, de novo scoliosis, who basically ended up with a spinal stenosis and needed surgery. This is the surgery what has been done, and you can see on the left side, 2 years after the surgery, a angle of 60 degrees and a kyphosis, 60 degrees kyphosis, and the PJK of less or a little bit more than 10 degrees. And when you go on the right side, 6 years after the surgery, the patient is now 69 years old. The PJK increased to about 28 degrees, and the general kyphosis is 28 degrees. However, this patient has just an aging spine with collapse of the discs above and some wedging of the vertebra. But basically, clinically, the situation is very mild for this patient. There is no need to do anything at this point. But it shows that within this restored spinal alignments, there are aging processes which can lead also to this BJK, but it's not necessarily an indication for an other treatment. This, again, is a failure of the posterior ligament complex with a secondary bony failure and disc degeneration. This is a different etiology, obviously. And you can see, again, this is a 62 years female patient, again, overweight. She had 4 previous lumbar spine surgery, and she has been seen for intractable back and leg pain and inability to stand straight. And you can see that she has a failure of the posterior ligament system, secondary, with a secondary failure of L1, L2, and disc degeneration. So she has a BJK angle of 32 degrees with this relevant back pain. So this is basically a primary pathology in the posterior elements, muscles as well as the posterior ligament complex. And the bony problem is a secondary thing. So the failure of the posterior elements initiated the bony failure in this anterior column combined with disc degeneration. You see here the MRI and the CT scan, which demonstrate the failure of the posterior ligament complex with facet joint incompetency, spinal stenosis, and end plate failure on both sides of L1 and L2. And there is certainly a fatty atrophy of the posterior musculature. The angle is here the 12 degrees as the patient is in supine position. And when the patient is upright, it's 32 degrees. That means this is a highly unstable proximal junctional kyphosis, which is quite a danger for a neurological deficit. So this patient has been treated, as you can see here, again, has been fixed up into the thoracic spine. There has been some vertebral column resection from posterior, and it has been instrumented from T3 to the sacral pelvis. After only a few months, a new PJK at T3 with cut out of the proximal screw in the disc space and failure again of the PLC with anterior dislocation of T2 over T3 and the risk of neurological deficit. So whenever you go higher, it will happen there. And how much this has to do with wrong calculation of the sagittal balance, I have my doubts, because we have seen again and again patients who have been properly aligned according to the measurements, yet they produce this junctional kyphosis. So there must be something else. I will come back to this. Here is a patient with an osteoporosis, another case, and fracture of the uppermost instrumented vertebra with a secondary PLC failure. So this is inverse of what I showed you before. Here's first the bony problem is, and then the secondary problem is the problem of the posterior ligament complex. So you see this osteoporotic spine in a 60 years old female patient with a history of multiple previous spine surgery, and she has osteoporotic compression fractures and a sagittal decompensation. She has been treated with a pedicle subtraction osteotomy at L2, as you can see here. And it didn't take long, only 2 weeks after the surgery. She had a fracture of the utmost instrumented vertebra with wedge compression fracture, and the angle of the PJK was more than 30 degrees. Again, this patient has been reoperated. The whole thing has been fixed up in the thoracic spine. As you can see here, there is instrumentation to T2, and it didn't take long. The patient developed a new PJK at the cervicothoracic junction, and this patient at this time had only very little cervical pain. So this patient didn't need to have surgery, but you see this is a pathology here with a malalignment, with a kyphosis, and yet the patient is fine for the moment, and this patient didn't need any surgery for the moment. But the big question is why there is a continuation of this falling forward of the head, of this malalignment. The patient goes back again and again in this malalignment. And there is I think this cannot be explained with our measurements. There must be something else which drives this kind of pathology and this clash of differently rigid spine sections. And I think there is a neuromuscular control here, which we cannot calculate in our equation at the moment when we do the surgery. And I want to show that here in this specific case. This is a 71-year-old female patient. This is a doctor, GP, with degenerative scoliosis and sagittal and coronal imbalance and invalidating back pain. She has been operated, as you can see here. 3 months post-operatively, she was pretty well. She was very happy, but already you can imagine that there is developing some kyphosis in the upper part. When you see her 10 months later, she developed a sagittal decompensation and a cervical kyphosis, and she had significant neck pain. And when you look at her very closely, then you can see that she has a C2 to C3 spontaneous fusion. She is spontaneously more or less fused between C4 and C7. The thoracic spine is almost fused in the upper part. And what happened is that this patient developed a subluxation between C3 and C4, basically as the only possibility to bring her back in the position she has been accustomed for her life. So again, there must be some balance control in the brain, which we cannot control with our mechanical surgical thinking. In this specific patient, finally, we had to fix even this problem in the cervical spine because she developed problems in her hands, in her arms, and therefore we were forced even to fix this. So this is another example to understand this whole variety of pathology. This is a variety where you can see a segmental dislocation. That means a translational dislocation with a neurological deficit. This is a patient, a 56-year-old patient with a history of chronic steroid use and rheumatoid arthritis and consecutive osteoporosis. She had previously undergone 2 surgeries, one for flat back deformity, and the last one, what you can see here on the pink picture, is the previous one with the PJK at the level of the thoracolumbar junction, has been treated with an extension of the fixation into T2. 2 months after this surgery, this patient developed again a weakness in the legs. This time the leading symptom was not pain, it was the neurology. And the CT was showing a clear dislocation of the spine between T1 and T2, with the instrumentation broke through the end plate, fracture of the vertebra, the last vertebra instrumented, and finally instrumentation failure. The surgery has been, again, has become necessary because of the neurological deficit. It has been elongated into the cervical spine, and the patient improved neurologically. But what is going to happen in the long term is a patient who is basically fused from C5 down to the pelvis. We don't really know exactly. Now, when we are summarizing all this, what I showed you, these different presentations of this proximal junctional kyphosis, then there is, of course, again, an attempt to classify these things, and it is specifically the group of Boachie who have tried to classify that. They have classified them in types, in grades, and whether there is a translational dislocation. Basically, everything what I showed you is here in this classification: the ligamentous failure, the bone failure, the implant bone interface failure, the combination of them, then the increase of the angle over time, and finally whether you have a translational deformity or not. And on the other side, there has been also an attempt to classify the severity of this proximal junctional kyphosis. This has been done by the International Spine Study Group, and you can see they have classified it according to the neurological deficit, the focal pain, the instrumentation failure, the change of the kyphosis angle, and the basically the type of the fracture, whether there is a fracture or just a fracture of the last vertebra instrumented or fractures above, and of course whether there is where exactly the junctional kyphosis occurs, because it makes a difference whether it's in the thoracolumbar junction or whether it's in the upper thoracic spine. So the question comes, obviously, what are the possibilities to prevent this, if we can prevent? And when we talk about that, we realize there are factors that cannot be influenced by the surgeon. And such factors are, of course, the increased body mass index. You can only say, I don't operate this patient. There is a decreased bone mineral density, which we have also no influence. You can treat these patients, but usually you don't have time, because if you want to improve it, it takes you a long time before you can basically say, now it's improved and we can do the surgery. And it's the age, and it's the multiple previous surgery, it's the difference in the pelvic incidence, it's the hip and knee parameters, it's the cervical spine and the upper thoracic spine, what is the condition, as I showed you, and it's the neurological parameters. And there is factors which can be influenced by the surgeon. For instance, the level of fusion to be instrumented, and here there is even specific literature about that, where it is said that when you have a, when you have a lumbar problem in the lumbar spine, and then you do a fixation, let's say a flat back syndrome, and you go up in the thoracolumbar junction, that means in T12 or L1, T12, maybe T11, then there is a higher incidence of a proximal junctional kyphosis in this specific location. And there are clear parameters which makes very probable, almost 70% probability, that you will have that when the patient is over age 70, when there is osteoporosis, and when the PJ angle is more than 8 degrees, then the risk that you have such a proximal junctional kyphosis is about 70%. Then, of course, it depends from the choice of the metal, the implants, how much is your density of implants. You know, this is a huge thing when you see all the screws from top down. What must be the impact on the spine for that? And then, of course, depending on the strong fixation, the upper end vertebra, then the osteotomies, the location of the correction, and where to stop the instrumentation, as I just mentioned, and so on. So there are factors which can be influenced and which you have to consider when you make an indication for the surgery. What are the preventive strategies we know today beyond what I just listed before? There is this discussion always about the vertebral cement augmentation. That means that you augment the last vertebra of the instrumentation, the uppermost instrumented vertebra. It's always said you should enhance that with cement, and maybe you should enhance the cement also with cement in the vertebra above, in the non-instrumented, and in 2 above. There has been studies about that, and there is in fact no real evidence that this makes a big difference. Of course, it is probably more important to decide for vertebral cement augmentation on the base of the bone mineral density. This is the more important factor than whether you will put cement in the instrumented vertebra or not. So it is has also some risks, as you can see here in this specific case presentation. We have a very similar case where there is a dislocation between the cemented vertebra, because there, again, this is a very rigid situation, and what is very bad consequence is when it comes to a fracture in a cemented vertebra, as you can see here in this specific case. And this, of course, will need a salvage procedure much higher, and it will be very difficult to take out the screws out of this cement. And so you have to think twice before you do this kind of cement augmentation. Then people say spinal hooks may lower the probability of a proximal junctional kyphosis. There has been some studies of that, and they have been shown that patients who have been treated with pedicle screws only have about 35% of junctional kyphosis, whereas those who have been treated with hook only, at least in the upper part of the instrumented spine, have only about 24%. Whether this is significant is also not really proven. there is this different ways you can anchor that with hooks, as you can see here. You go to the transverse process, but you can also do combinations with the laminar transverse process. Then there are other measures, and you know, the big discussion here is whether you have some instrumentation or specific rods with a different rigidity and some ligaments to use at the upper end of a fixation to basically to lower the chance of an proximal junctional kyphosis. And here have been this kind of ligaments or ligaments or straps to use in the spinal processes, or the sublaminar wiring, but not with wires, but with ligaments, which should give a more elastic, not as rigid fixation like pedicle screws. Again, there is not really good evidence, at least today, because we have no real prospective studies comparing different techniques with each other, that this helps. But of course, everybody tries to do what is possible to avoid this kind of pathology. So in conclusion, maybe as taking home message, what we can say here is that most studies report PJK in approximately 20 to 40% of all patients who undergo spinal instrumentation and curvature correction in adult spinal deformities. The phenomenon of the PJF, that means of the failure, is distinct from the kyphosis. So not every kyphosis is a failure or has to be treated, but if it is a failure, then of course this is mostly an indication for treatment, and this is an indication that there is a relevant structural damage in the posterior ligament complex and or in the vertebral body. The risk factors are pretty well defined, as I mentioned in my presentation. However, we still do not have clear indication guidelines when we should do what and how far we can go, because everybody tries to basically develop its own experience. But I assume that in the years to come, the study groups who can pool a lot of cases together, they finally will deliver that for us. And there is, of course, definitely a necessity for a standardized classification, like in everywhere, as we just discussed today about the scoliosis. If we want to compare results, if we want to measure outcomes, we have to classify so we can compare the different cases with each other, and the cases are identical for comparison. And the same thing is, of course, for the severity of the problem. Also here we need certain scores which allow us to compare the patients with each other, so we do not compare apples with pears, and this is very fundamental. So this is still a huge problem in spine surgery, and specifically in adult deformity surgery. Those who do these elderly patients, we have seen very impressive cases during this afternoon, and we are still struggling to classify and to structure the knowledge about this kind of pathology. Thank you very much.
Dear Max Aebi, yeah, it was great talk, really. We learned a lot about the reasons and the techniques how to avoid PJK. Are there questions?
Yes.
Yes, Onur.
Aebi, thank you so much for your nice presentation. We are learning every time new things from your presentations. In some of your cases, Aebi, you let the rod longer than you need. Are you are you thinking that I'm going to have PJK in the future so that I can use it as using dominoes for it?
Yes, in fact, we do that systematically. We do that in the proximal one, but we do that for sure in the distal one, because if you have to extend the fixation, then you just can hook on with dominoes. But I have to warn you, we have a case in our hospital which has been the rod a little bit too long, but it was by intention, because we were seeing that he probably will need a further fixation further down. And this guy has now will sue us because we have not cut the rod. So that's the, maybe you don't have this problem in your country, but that's the problem in our country.
And may I ask a question to Lamartina? Claudio?
You can unmute, yeah?
Yeah.
Okay.
Claudio,
Yeah.
I've learned the technique from you and from Bariano, the kickstand rod and the tie rod technique.
Yeah.
In the coronal plane, some of other friends are asking it, how do they use the double rod technique there in the iliac wings there? Is there a trick point that you can say to us?
Are you asking me about the coronal alignment?
Yes.
Okay.
While you're correcting the coronal balance, okay?
Yes, please. Sorry.
Then you're balancing the spine in the coronal plane. You're losing some sagittal balance there. And I asked you last time, how do you correct it? One of the trick point is you distract on the coronal plane, you put an extra rod to the other side, then you compress it so that you can bring the spine back to the sagittal plane.
Correct. The key point is if you distract in lumbar area using, for instance, a kickstand rod, you reduce the amount of lordosis. There is no discussion about this. Vice versa, if you put in compression in the extra rod, you preserve or increase the lumbar lordosis. That means when we have to perform the correction in coronal plane because of different problems, especially when the deformity, when the coronal malalignment is in the side of convexity, we use this technique, but we pay attention. First, we put in compression one side and then distract in the other, just in order to avoid to lose lumbar lordosis.
Thank you so much.
I want to ask Max Aebi, what is the most important reason of proximal junctional kyphosis? Is it not considering the sagittal balance well? Is it our design of construct or osteoporosis? What is the most important one?
I think the sagittal alignment is very important, but it's not enough. It's not the only reason. We see patients with not a perfect sagittal alignment and they don't develop an proximal junctional kyphosis. I think the most important thing is A, the quality of the bone, and B, the quality of the posterior ligament complex, because this is changing with aging. Older the patient, purer is the tissue quality, and this is one of the major reasons why this is happening. And I think it's happening because these people have a central control over their body perception. People who have lived for 60 years in a certain position or 50 years in a certain position, you cannot change just like that when you go and you correct the axis which you can measure on the X-ray, because you cannot change the brain at the moment. We don't understand that. And I tell all my young colleagues, if they want to do research in this area, they should do research from the brain and not measuring more and more the spine. We have to understand what's happening in the brain, because the brain controls this position.
Right. What about, yes, you are right, exactly. Do you think that we are doing too rigid fixations? Then the future will maybe less rigid fixation than allowing some elasticity of the spine, so that the PJK will not happen.
Of course, this is would be a logical consequence. You are absolutely right. but there has been a lot of attempts to create instrumentation which are not as rigid as the ones we have today. But until today, I think nobody has really proven that with a more flexible instrumentation, you can avoid this problem. But I think Claudio has probably something to say here. My perception is, until today, with less rigid instrumentation, we cannot solve this problem. But Claudio, I don't know what you mean.
I agree with you. I believe that if you consider our surgery in adolescent, in adult, there is no doubt we collect more PJK or PJ failure in adult than in adolescent. This is a very good demonstration that you are right when you say the quality of bone is important in producing, in creating PJK. And also the age, because of the mental attitude to be more kyphotic. I agree, I totally agree with you about this point. Speaking about the stiffness or the kind of instrumentation, this is something that cannot change what I said, we said a few seconds ago. That means we can try to solve a problem creating something that can compensate the problem. But the problem is the quality of the bone, the age, the mental attitude, and so on. Even if we create a magic instrumentation with a totally different amount of stiffness in cranial part in comparison with the caudal part, we cannot solve the problem. The problem is in a different part of.
Thank you. There's one more question. Do cervical lordosis has more influence on global fractal balance than lumbar lordosis? What do you think? Cervical lordosis.
If I shall answer this, I mean, you know, in younger patients, I think the cervical lordosis is very adaptive. People can adapt very well with the lordosis. You see young people who have a complete straight cervical spine and you don't really understand why. And suddenly they can bring it back in a very good lordosis. As the people get older, of course, again, you have a certain stiffening in the cervical spine. And then the lack of lordosis in the cervical spine contributes also to the global alignment problem. But in younger patients, they can compensate that very well.
Okay. Yes, I think we should stop here. We are quite out of the time limits. Thanks a lot to all of you, Dr. Max Aebi, Claudio Lamartina, Richard Asseker, Marcos Massini, and Onur Yaman, for giving the time and very nice lectures, very great lectures you have given the opportunity to share with us. Thank you, and wish to see you in live meetings in the future. Goodbye.
Thank you.
Bye, all of you.
So much.
Thank you.
Thank you.
Goodbye.